Good evening, everyone present here. I am Faraz from IGCP Group. Welcome all the participants on today's webinar, and that is on a very important topic, that is elderly, frail, and forgotten optimizing diabetes care in geriatric patients. And as we know that this topic is a very much important, so we need someone who is expert. So he don't need any introduction. So I would like to invite a guest for this webinar, none other than Dr. Bansi Sabu sir. And let me share some of the achievement of sir. Sir has done MD, MNAMS, MSc in endocrine from UK, and PhD and fellow in American College of Endocrinology FACE and fellow International College of Nutrition FICN Canada, and he is a diabetologist, endocrine and metabolic physician, Ahmedabad, India. So without any further delay, I would like to invite sir and hand over this webinar to sir. Sir, the stage is yours. You can proceed from here. Over to you, sir.
Thank you. Thanks for kind words of introduction. Thank you, IJCP, for giving me this wonderful opportunity. What I'm going to talk in next 20 minutes, it's an elderly care where optimizing diabetes care is very important. They are not only elderly, but they are frail. And why we have written forgotten? The reason is very simple, that most of the primary care physician, while treating geriatric patient, they are forgetting they are elderly and they are frail. Don't be very aggressive while treating diabetes care in a people who are above the age of 65. For this talk, I don't have any conflict of interest, so no financial disclosure. Diabetes in elderly in Southeast Asia, as I am chair of International Diabetic Federation of Southeast Asia. This paper of IDF is talking that still we have highest number of people who are becoming diabetes in the age group of between 60 to 64. So we are going to have a lot of people above the age of 65 who have diabetes duration of more than 10, 20 years. But unluckily, yes, we are developing diabetes in younger age thanks to all new medication and thanks to doctors that they are surviving for another 20, 30, 50 years and they become elderly people and they come to us for the treatment. It is a category itself. Like when we are talking of a special category, like the same way, a geriatric patient is having separate category and they should be considered when we are dealing with these patients. But two things we must remember when you are dealing with geriatric patient, that how long the duration of diabetes they have. Suppose someone comes with the age of 67 with a duration of diabetes of 20 years or 30 years, or someone comes with a diabetes of only 2 years. So these two patients are completely treated differently. What about their complication? If they have underlying complication, the treatment will be completely different. Similarly, their physical and mental well-being, how much economically and socially they are deprived, whether they have emotional support or not. What is their expected life? You are seeing someone at the age of 78 and already having some terminal cancer, a very frail patient. You don't know that their life expectancy is not very high. So you have to deal with these geriatric patient, looking into all these things, very, very important. We call it like a geriatric syndrome. It's a phenotype of diabetes in the old days. They have imbalance, they have incontinence, they have impaired vision and hearing, they have immobility, and they have impaired intellectual also. So actually speaking, they are having 5 important I, that is 5 Is, and that makes them a person with geriatric syndrome. Conceptually, it has been written that overall health category is very important. When they are in very good health, you have to be very tight control. Still HbA1c, you want them to have less than 7.5. But someone who have already moderate to severe dementia and stage medical condition, even keeping A1c of less than 8.5 is also okay. So this is very important when you are treating these geriatric patient. What is your target? What HbA1c you are looking for this patient? The oral drugs for these patients for diabetes, you avoid the medication. which will lead to hypoglycemia, like sulfonylurea. You avoid like glitazone, which can be fluid retention. They may have underlying heart failure. You may avoid alpha glucosidase inhibitor because they may have GI side effect. You may avoid DPP4, which is more or less out of these molecules are tolerated, but they may have history of pancreatitis. You may avoid or give SGLT2 inhibitor depending on how much the risk of infection, which they have urinary tract infection. Make sure that you check care of their frailty. The frailty score is very important. That scoring also gives you that how much bone loss they have, how much osteoporosis they have, and that will also give you the idea of what is their immobility, how much risk of getting fall. All these are very, very important. So when you are looking for frailty, you are worried of hypoglycemia. A diabetic patient may be on multiple medication. They may be on a regular medication, but suddenly someone gives them quinolones and suddenly they may go in dysglycemia or hypoglycemia, or maybe an NSAID that may lead to them a renal dysfunction and they may go in hypoglycemia. So their polypharmacy is also very important when you are dealing, because you are worried of hypoglycemia, or some of the molecules which they are taking which may lead to hypoglycemia, like sulfonylurea or insulin. The challenges of hypoglycemia are very, very high because symptoms are non-specific. Sometimes they are misdiagnosed, sometimes misinterpreted, sometimes family member is not there. They are all alone in the house. They may have unaware of all these symptoms also, and they may have underlying dementia also. So multiple comorbidities in old days, multiple medications, they may be on insulin, sulfonylurea, and hypoglycemia, unawareness. All of these are really challenges with the person with above the age of 65 or 70, having social isolation, dementia, depression. They are more at risk of developing hypoglycemia. Risk of hypoglycemia definitely low with the patients who are on DPP4, SGLT2, and GLP-1 in compared to glitazone, in compared to sulfonylurea. But definitely sulfonylurea, glinides, insulin, they all are at a higher risk of hypoglycemia. Different glucose lowering agent definitely will increase the risk of hypoglycemia, like sulfonylurea and insulin. Biphasic insulin are very, very risky as far as hypoglycemia is concerned. I'm very much worried because I don't use biphasic insulin. If I use sulfonylurea, I always try to use short-acting, like nice short-acting sulfonylurea. I am very fond of using DPP4 and GLP-based therapy, which does not cause hypoglycemia in these patients. The treatment design containing sulfonylurea and insulin were with higher hypoglycemia events, and cost for hospitalization definitely will increase. If suppose someone develops hypoglycemia and you are worried of some safe drug, you are worried of putting them on a continuous glucose monitoring because of the cause, but actually one episode of hypoglycemia can lead to a lot of complication, and hospitalization itself will increase the cost other than emotions, compliance, and many more factors of related to hypoglycemia. And they may fall also. They may have fracture because of that. Hypoglycemia rate and cost were consistently higher. We started on sulfonylurea compared to DPP4 inhibitor. Sometime before a few years, we used to understand that DPP4 is more costly, but actually it is not. Now it is off patent, so the cost has come down significantly. But even when it was costly molecule, the risk of hypoglycemia was negligible in compared to sulfonylurea. It was better to use this type of molecule. Incretin-based therapy, actually they are secretagogue, but they are still not causing hypoglycemia because they are glucose dependent. Unless glucose increases, they will not increase insulin secretion from the pancreatic beta cells. And that's the reason they will work only when sugar is high. They will not work when sugar is low. So there is no risk of hypoglycemia. While sulfonylurea, even the mechanism of action is also same. They are also secretagogue, but they are independent of glucose level, and still the insulin will be secreted. Now, as it's not only GLP, now GIP had also come in a big way. We have dual combination which is available, and it is the GLP-1 which suppresses glucagon. So the GLP-1 which are injectable therapy, and GLP-1 and GIP both in combination, actually that reduces the risk of hypoglycemia. So alone GLP-1 is going to suppress glucagon, while GIP actually will prevent the state of hypoglycemia. So when you are using a molecule which is GLP-1 and GIP in combination, actually risk of hypoglycemia in combination is less in compared to the molecules who are only on GLP-1. Glucagon response to hypoglycemia in elderly patient will be again suppressed. So it's better, to use the molecule. If you want to use GLP-1, it's better to use GLP-1 and GIP in combination for either obesity or for diabetes management, because that will not suppress that much glucagon, while it will allow glucagon to respond for hypoglycemia. GIP and GLP response to hypoglycemia in elderly patients. It will help us to increase the glucose level whenever there is a glucose level goes down, because it is not suppressed by alone by if we are using GIP. If you are using alone GLP-1, then the suppression will be higher. Even DPP-4 also suppresses glucagon level. Now, we were worried of SGLT2 inhibitor. There is a one paper, and there are multiple papers which talk that SGLT2 is very effective and very safe. We also use SGLT2 because of clinical heart failure, subclinical cardiovascular disease. It's very, very effective medication for sugar control and very safe also. But you will be more worried in elderly person for their genitomycotic infection, for urinary tract infection. They may have prostatitis, they may have underlying UTI infection, and that may lead to increase in that infection rate. So please be sure when you are using SGLT2 inhibitor, one is for the hygiene, and second is also recurrently check the urine level also and ask them, particularly for urinary tract infection or genitomycotic infection. So clinical implication, I'll be very happy to use the patients on DPP-4. That's very safe in compared to even all other molecules. Even we may not have great data with DPP-4 in compared to like what we have data with the SGLT2 and GLP-1, but definitely DPP-4 are great molecules which will not increase the risk of hypoglycemia. The other molecules is metformin and a carbose, which is also not going to increase the risk of hypoglycemia. When hypoglycemic agents can be avoided, nothing like it. But if can't be avoided, then educate, and put the patient on monitoring. Maybe on self-monitoring, maybe on continuous glucose monitoring. Educate these patients that they should not develop hypoglycemia. This is a tool to identify hypoglycemic risk. Actually, we should give to all our patients who are at very high risk with the prior hypoglycemia, or those who have, hospitalized for hypoglycemia. They are again more at risk of developing hypoglycemia. And these are the patients who should be taught about this tool to educate them for the risk of hypoglycemia. These are some of the flyers or education material which we give to patients for when they know about the low blood sugar, what they should do, how the type of feeling they may have, and they should take a immediate release glucose tablet which is available in market. Hypoglycemia detection device and apps are also available. I mean, with modern connected CGM, but not only that, there are some sensors, and with AI induced, the patient will able to know that they are developing hypoglycemia. So that's very, very interesting. This hypoglycemia management education, it is the educating the patient is the most important thing. But once they consume 30 gram of oral glucose level, then they can have bread, cup milk, and biscuits, and cup of full of fruit juice. Otherwise, you give them 25 2% which is available easily, and 50% extra is not very available. 100 ml or 50 ml we give them immediately, and once they get the sugar level normal, then we give them some sort of a snack, so that risk of hypoglycemia for further decreases. But make sure they are getting admitted or they are under observation and they don't develop recurrent hypoglycemia. Frailty means they need to change their diet. What diet program which we have to give? High protein intake, and that's most important thing. Along with that, high vegetable and high fiber diet. That's very, very important, which will help them to reduce the weight and to make them more healthy, and their protein mass to be built up in this. Healthy diet will have more of a Mediterranean diet, which contains meat, refined grains, and snacks and sweet, which is to be stopped. Vegetables, whole grains, fruits, and fish, which is to be increased with more amount of proteins and more of optimal energy. The physical activity and fitness, I suggest them normally for increasing their muscle mass, muscle strengthening exercise, going to the physiotherapy, or better, they can go to the gym and make their muscle mass stronger. So their physical activity can be increased and it should be increased. And we do normally BCA also for these patients just to know about their physical activity and fitness and to know their muscle mass too. This is in 2025. ADA is writing the guidelines since long, and every year there is a one separate section which is talking only on elderly patients for the standard of care, which is talking about the self-administration of medication, ability to use diabetes technology, anxiety, depression, diabetes distress, mild cognitive impairment or dementia, or coping skills for the medication, for mobility, and for what matters most. So the mobility is like foot complication, leg weakness, neuropathy. All of these are very important to understand the mobility of these elderly people, and we should try to see their quality of life and life expectancy, which is most important when you are dealing with an elderly patient. The treatment goal, as I told you, the goal of A1C to get control may be again different with a healthy elderly, complex elderly, and very complex. I mean, someone who's poor prognosis, you can keep less than 8.5. But what about the blood pressure? That is 130 by 80, which is reasonably good. But for very complicated, even 140/90 is fine. Statins by lipid association, this can be used and consider likelihood of benefit from this statin, even in a patient who is complex elderly patient. This is one important chart which I think all of us we should put it on our behind our consulting room, just to make sure that whatever the gliptin, whatever the SGLT2, whatever the medication which you are giving, simultaneously you just calculate the EGFR. Whenever EGFR goes less than 30, there are many molecules which you either you have to reduce the dose or you have to stop it. There are molecules which can be given up to the EGFR of less than 15. Even it can be initiated even when the EGFR is less than 15, and you can continue this medication also. To summarize my talk, hypoglycemia is one of the major challenges in optimal and holistic type 2 diabetes management. It is an bigger challenge in the elderly because nobody is at the family or nobody is going to take care. It's really difficult for them. In emergency midnight, what will happen to them? For hypoglycemia, avoiding hypoglycemia should be the strategy to choice rather than managing hypoglycemia once it happens. So, I mean, in advance, we have to think of that hypoglycemia can be stopped. Gliptin and SGLT2 are good drug because they does not increase the risk of hypoglycemia. Polypharmacy, we all have to worry because of many medications which are self-marketed and they can take on their own. Patient, especially the elder agents, should be educated to avoid and recognize and manage. With this, I thank IGCP and all those who joined today. In the elderly, diabetes care should be very, very personalized because aging is not one size which fits and all process. Thank you very much. And those who are interested more in diabetes, we have World Congress of Diabetes India, which is from 12th to 15th of Feb at Hyderabad. In this meeting, we are going to have more than 5,000 delegates. We also have going to have one dedicated meeting of type 1, which we are doing since last 4 years. This year meeting is in Kanpur. Dr. Rishi Shukla is doing. Me and Archana, who have made the program in the part of this tie-up, and we are as a founder for this particular activity, which is dedicated only for type 1. So those who have interest in type 1, they can come and visit us for 6th and 7th December. Thank you. Thank you very much. I am once again thanking IGCP for giving me this opportunity.
Thank you so much, sir, for taking out your important time and sharing your knowledge on this topic. I definitely think this session knowledge is going to help all the participants on the practice too. Sir, we have received some questions, sir. With all your permission, shall we take these questions one by
Yes,
one?
yes.
The first
Please.
question is, sir, how should glycemic targets be individualized for frail elderly patient with multiple comorbidities?
Yes, so I have written there is a ADA guideline also where you can keep it even less than 8.5 is fine. You don't be very tight.
Thank you so much, sir, for sharing your point on that. Moving forward, we have second question, sir. What are the practical challenges in selecting appropriate anti-diabetic medication for geriatric patient with renal or hepatic impairment?
So GLP-1 and SGLT2 are best, but if renal dysfunction and decrease so much, so be less than 15, then probably only insulin.
Thank you so much, sir, for answering one last question, sir. What strategies can be improve medication adherence and monitoring in elderly patient living alone
One
or
is
with?
these applications are good enough to increase the compliance, and second is definitely awareness and education.
Thank you so much, sir. One feedback from Dr. Minakshi, she has written, thanks for this amazing presentation on this topic. Sir, as there is no
Thank
more
you.
further questions, with all your permission, shall we conclude this webinar for today?
Sure.
Yeah, sir.
Thank you.
Welcome, sir, and we would like to see you in future also with different topics, sir. Till then, take care of yourself. It was great honor to have you, sir.
Thank you.
Have a great day, sir. Thank you.